Hello. In labor, luckily for most of us, things go fine. We have maybe longer, maybe shorter labors, but they are fine. However, for those that have challenges, it is helpful to know what are the most common ones and how to react if you find yourself in that kind of a situation. It's also important to understand that even when we have certain challenges, it doesn't mean that now you've entered this danger zone that is going to be hard to navigate through. And I'm going to touch on the three most common ones that we see. Challenges because they're just not expected, but they're still quite normal things in labor. And the first one here is long pre-labor. When someone says to you, I was in labor for 34 hours, and you're pregnant, about to have your baby, you probably think, ooh, I wish I will not have that. However, you've always got to remember that how people define their labors can be slightly different. For some people, they're busy doing something when labor starts, and it isn't too uncomfortable, so they manage to almost pretend they're not in labor. So by the time they start to feel it, they will be already in the active phase of labor. So they've kind of cut out the first 2-3 centimeters and the time that comes with it. So how you define yourself in labor may affect whether you find yourself in long labor or not. So if you're just excited or scared or just very unsure of the signs, sometimes you find yourself in this early labor, early in hospital, but actually you are perhaps not in full labor yet. So not saying that you are wrong or you shouldn't have gone to the hospital, but you may need to respond to this situation depending on how dilated you are. So when you're in active labor with 3 centimeters dilated, usually you proceed as normal. But if you find yourself in this long, early labor, the most important thing is to try and get some rest. Go to bed, sleep if you can. Practice your breathing, and then make sure you get food, nutrition. Make sure that you understand that the body is really a machine in the sense that it needs oil, it needs lubrication, it needs liquid, otherwise it's not going to function. Sorry, I'm going to go back a little bit. Long pre-labor. The other thing is, if you've ended up in hospital, you found that you exhausted all of your options, you don't know what to do anymore. There are drugs that can be useful. They're just not drugs there are some drugs that are going to slow things down and not really help, and then there are other drugs that may give you the break or the rest that you needed. And if you really don't get into full-on labor, you stay in this long pre-labor stage for long, sometimes induction is going to be needed or necessary. And I'll talk about that later. Now, this posterior baby is a common thing, common term, definition, and it has a negative association. Many people who know about this posterior baby, sunny side up, back-to-back labor, they think about it with horrors, even before going into labor, because they've been told it's bad. Truth of the matter is that the shape of your pelvis, the shape of your baby's head, as the baby's traveling through labor, quite likely at some stage it's going to face up. Usually because it needs resistance in that position, and particularly because you know and you've learned, and you will do it, to move, lean forward, help the pelvis to rotate like that, and then you move your legs and you make a bit of hip movement, the baby will turn. And eventually, it's usually born facing down, if you're in the back position, or at least facing the bottom of you. However, sometimes the baby doesn't turn so easily, so it keeps on looking up or back to back. And what happens then is that the pressure of the baby's back on your lower back is so heavy that it feels painful, more painful than you can easily cope with, and sometimes you have to be reminded. Most important thing is mobility. Lean forward, rock, 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 and baby will rock with you. If it really doesn't work, sometimes drugs may be helpful. Give it time and be mobile. Third thing, what we often see is not enough urge to push. So the bearing down isn't strong. You don't feel like you need to push, but somebody has told you that you should. Usually this is because the baby just hasn't gone low enough. It's still up in the pelvis where it's not pressing on the right nerves. So you need to wait. Even if you're 10 centimeters dilated, as long as the baby's okay, you move around, you lie down on your side, again, relax, pee, drink, a little bit of food, mobility. Wait an hour, then the baby usually moves and the urge comes to you. The other reason would be that if you have an epidural, then sometimes the urge is blocked, the numbness is too strong, so the brain is actually not getting the message. And then the same thing applies. As long as the baby's okay, you wait for that urge. Let the epidural wear off, wait for a proper urge. Otherwise, the likelihood of having to use vacuum and forceps is too high. Which is the next thing? Common medical interventions. We have to face it that they are quite common. They might be chosen by you, they might be necessary, or they may have been one of those things that just happen in labor. Having said that, if you can avoid them, you avoid them. But if you cannot, don't dwell on it. Make the most of everything. And remember, epidural, it doesn't mean that now you're lying totally flat on the bed, you're going to have difficult birth and not feel the urge to push and everything's going to be bad. It also doesn't mean, yay, labor is now pain-free, everything's going to be fantastic, it's so easy. And it means neither of those things for all women. For some, but for most, somewhere in the middle. A little bit of everything. If you want to have an epidural, make sure you're active, because your body is not going to remind you to be that, because you will be slightly numb. Move around, change positions, but you don't jump around the room. Be creative on and around the bed. Pee. Every single hour you have to pee. If you can't pee, even the catheter is better than no pee. And try not to start the epidural too early. Make sure it wears off at the end. Wait for the urge to push. That way, even if you have an epidural, you maximize your chance of a natural or normal vaginal birth. Next, medical intervention. Commonly used and sometimes necessary is the induction of labor. Typically, I would not worry about, or I would suggest that you don't worry about, an induction of labor at all until you're at that stage in your pregnancy where perhaps you do have to. You're faced with that you are more than 40 weeks pregnant, there are no signs of labor, or if there are any diseases or challenges, for example diabetes, which would be probably the most common one, or a baby that doesn't grow, which is rare, that can happen. In the absence of all of this, I wouldn't worry about an induction, because should you need one, there is plenty of time to explain to you what will happen. And in any way, you're not going to remember all of what I'm telling you now. You're going to have to make it more personal. So you will sit down with the people that are there and that are going to do this for you, and you will discuss it in greater details. What is important is to know that an induction is a method to try and avoid jumping from a normal pregnancy to a cesarean. It's your chance of going into labor, even if your body hasn't done so for whatever reason, and you still got probably at least 50, if not 60, 70% chance of a normal birth. But it is a slightly different way of going and staying in labor, which is why it's probably worth avoiding it unless you need it. Going back for 1 minute, remember what we said in the very first session. Pregnancy is 37 weeks to 42 weeks. Estimated due date, or EDD, is a date that is calculated when you're early in pregnancy for when you're 40 weeks. And it's thought that if birth happens somewhere between 37 and 42 weeks, it's normal and it's safe. But anytime after 41 weeks and 10 days, or close to 42 weeks and later, the risks of problems increase, which is why that's usually when the set induction date is for those that haven't given birth. Now, if you have to be induced, you have to remember it's still that same journey that we've discussed, 0 to 10 centimeters and then about an hour of pushing. Pre-dilation, so before you're 0 centimeters, before you go into strong active labor, there needs to be a preparation done. And in hospitals, this is typically done so that you come in the evening before you're supposed to be fully induced. There's a prostaglandin tablet that is put in your vagina. It's left there for a few hours, and normally you don't get much response from it. Often you need the second tablet and maybe even the third tablet. But after about after about a few hours, up to 10-12 hours, usually, if no signs of labor, then you will get an IV line, and somebody will break the membranes or do a vaginal examination, put a little hook up the vagina and sort of scratch the amniotic membranes. The fluid will come out, some of it, and the IV line with a drip will create the contractions that otherwise the body would have naturally done. Induction can take time to work, and it is very often more painful than normal labor. It comes on quite fast and you may not be prepared. It's harder to spend time at home and let the time factor play in your advance. So with induction, it's much more common to use other drugs for pain relief, and sometimes more successful. Most important, I would say, if you need one, go through it as if it never happened. And just pretend you're in normal labor. Again, can-do mindset. Just do it. Even if you're attached to an IV line, you're attached to a monitor, you're close to the bed the whole time. You can still pee, you can still walk around a little bit, and you can be mobile as if you weren't hooked to all those things. And that way you maximize your chance of normal birth. Unfortunately, sometimes either there's a risk or baby showing some signs of distress, and the labor has been going on for too long, and then you have gone so far, you're already 10 centimeters, you're ready to give birth, and you even started to push, but it just doesn't seem to progress really well. Or you have an epidural and you've been pushing, but it hasn't been, again, very successful. If the baby is kind of knocking on the door saying, look, I'm not feeling very well, which you would normally know because you are being monitored and the heartbeat of the baby is being displayed somewhere. Now, if this goes together, it's taking longer than expected, you're not feeling urge enough, you don't just feel like you can easily get the baby out on your own accord, and the baby's in distress, then forceps and vacuum, in addition to a cesarean, but forceps and vacuum are options available. I'm not going to necessarily dwell on it by saying again and again, move around, eat, We've talked about it many, many times, but you lessen your risks by doing all of those things. But if it came to this, that you actually were told that baby needs to come out by forceps or vacuum, first thing to ask, is there so much distress that I cannot change my position one more time? And do that one more time. Change the position, empty the bladder. If still no success, then basically think of forceps and vacuum as a last resort to do a vaginal birth, little bit of assistance, not having to do a cesarean, And these methods, either the forceps, which is metal blades that are attached around the baby's head and somebody pulls at the same time as you push, or a vacuum, which is more like a plunger, small plastic plunger, maybe the size of this, little cap that goes on the baby's head, and at the same time as you push, someone pulls. I don't think it's going to be helpful for you to go into any more details about this, but you should know these are things that exist. They are quite commonly used, and they are not necessarily a huge intervention, but you try and avoid it with the positions, with the food, with emptying your bladder regularly. You have to usually have an episiotomy, or cut in the perineum when this is being done, because there's less time to let the perineum stretch. But aside from that, the birth is handled in a similar fashion and the aftermath. This session is not meant to give you the detailed information about the cesarean, but you should know that if we are facing a situation where the risks are more than of continuing labor are more than to get the baby out quickly, sometimes a cesarean needs to be used. Typically, if the baby is in distress, the progress isn't very good, or if there are some factors there that are while you're still pregnant that will show us that probably C-section is a safer way of doing things, like breech, twin birth, or previous C-section. Sometimes you just got to accept that a C-section, or cesarean section, is nowadays a safe and available method that is used for probably 20 to 30% of all births in any Western communities. Elective and emergency C-section, it's just simply based on whether it's a decided beforehand or an emergency treatment that is done during labor. And if you have an epidural, it's used, it's topped up, and a stronger effects are given. Otherwise, you've got spinal anesthetic, which is similar to the epidural, but a one-off injection instead of a continuous flow. And every now and again, you have to have we use general anesthetic to help people during C-section. It's not preferred and usually not done, but if there's a big emergency, then sometimes it is the case. And again, it's not something that a C-section, it affects a lot of things. It affects breastfeeding, it affects the moving around after recovery and the time with the baby, bowel motions, you have more risks after the birth. Generally, what we call morbidity rates are higher than a vaginal birth, but major complications are rare. And if you need a cesarean, you'll have a drip, you'll be given medications to make sure you don't have any backflow of food, and you'll be monitored very, very closely, but typically you're awake. The operation takes about 30 to 60 minutes. The husband can usually be there, and typically you'll have maybe 3, 4, 5 minutes with the baby once it's born before it has to be taken away. I hope this was helpful. Thank you.